Welcome to This Explainer. Let's jump right in. Have you ever thought about the massive, totally invisible language humming quietly in the background of, well, literally every hospital, clinic, and doctor's office out there? We're talking about the ICD-10. It's this incredibly intricate system that takes the messy, complex reality of human ailments and translates them into a very precise alphanumeric code.
It's kind of crazy when you think about it, right? How do you categorize every single thing that can possibly go wrong with the human body? Well, the folks behind the ICD-10 didn't just try, they actually pulled it off. Honestly, if it can happen to a human body, an injury, a super rare disease, there is a specific, systematic code for it in this matrix. But to read it, you've really got to understand its strict syntax and grammar.
Okay, let's look at our roadmap for today. We're going to cover 1. Cracking the medical code, 2. The index and the tabular, 3. The grammar of ICD-10, 4. Small words, big meanings, 5. Navigating exclusions and instructions, and finally, 6. Why this precision matters.
Section 1. Cracking the medical code. Who built this matrix? Let's start by looking at exactly who built this thing and who holds the reins today. The foundation, the 10th revision of the International Classification of Diseases, was actually originated by the World Health Organization way back in 1993. But here's the catch. The WHO version doesn't cover all the nitty-gritty details a specific country might need. So here in the US, we use a clinical modification maintained by a group known as the Cooperating Parties. This includes the American Hospital Association, the American Health Information Management Association, the Centers for Medicare and Medicaid Services, and the National Center for Health Statistics. Basically, these 4 groups write the rules.
And those rules govern a system where codes range from a minimum of 3 to a maximum of 7 characters. Each time you add a character, you're zooming in for a much higher level of medical specificity. A 3-character code might give you the general neighborhood of a disease, sure, but it's that 6th or 7th character that tells you exactly where it is, how it happened, or even if it's the patient's very first visit or a follow-up encounter.
Section 2. The index and the tabular. The coder's 2 main tools.
To actually track down these 7-character codes, medical coders use what's basically a 2-part secret decoder ring. Think of the alphabetic index on the left as your search engine or your dictionary. It's just a massive alphabetical list of main terms, conditions, and subterms. Then, on the right, you have the tabular list. That's your encyclopedia. It's highly structured into 22 chapters, broken down numerically by body system or condition.
Now, navigating these 2 tools requires a really strict chronological journey. You can't just bounce around. Step 1. You always start by finding your main term in the alphabetic index. Step 2. You carefully review any subterms indented right underneath it to find the best match. But you aren't done yet. Step 3 requires you to take that preliminary code and officially verify it in the tabular list.
So the absolutely crucial point here is what we call the golden rule of ICD-10 coding. Never begin your search in the tabular list, because that will almost certainly lead to errors. And never assign a code based on the alphabetic index alone. The index might get you pointed in the right direction, but finalizing that full, accurate code, especially those vital 7th characters, can only be done in the tabular list.
Section 3. The grammar of ICD-10. Abbreviations and syntax.
Just like English, or any spoken language really, this alphanumeric system has its own strict grammar and structural cheat codes. Take the placeholder X, for example. I think this brilliantly illustrates the system's foresight. Sometimes a code absolutely requires a 7th character, say to show it's an initial encounter for an injury. But what if the base code only has 4 or 5 characters? You can't just slap that 7th character onto the end. It literally has to sit in the 7th position. So coders drop an X into the empty spaces. This keeps everything perfectly aligned, and it gives the system room to expand later on without breaking any of the existing rules.
You've also got to know your abbreviations, specifically NEC and NOS. NEC stands for Not Elsewhere Classifiable. Think of this as your other specified code. You use this when the doctor knows exactly what's wrong, but the rulebook simply lacks a specific code for it yet. On the flip side, NOS stands for Not Otherwise Specified. That's your unspecified code. You use NOS when the system has plenty of great codes available, but the doctor's actual documentation just doesn't give you the detail you need to choose one.
Then we have the combination code. This convention is a total game changer for saving time and space. Instead of stringing together multiple codes, a single combination code can classify 2 related diagnoses.
Or it can efficiently tie a definitive diagnosis right together with its common symptoms or complications into one neat little alphanumeric package.
Section 4. Small words, big meanings. The power of and with.
Now, what's really interesting about this slide is how everyday words we toss around casually all the time, have shockingly powerful, specific legal meanings in the coding world. You kind of have to reprogram your brain's grammar center. When you see the word "and" in a code title, it actually means "and or." So a code for tuberculosis of bones and joints works if the patient has it in the bones, the joints, or both. But the word "with," that strictly means associated with or due to.
The sheer power of the word "with" is immense. The classification inherently presumes a causal relationship between two conditions. If they're linked by this word, it connects the etiology, the cause, with the manifestation, the symptom. Coders actually have to code these conditions as related, even if the doctor didn't explicitly write down that they are linked. The system itself builds the bridge just through that one tiny word.
Section 5. Navigating exclusions and instructions. Red lights and yellow lights. You can think of these as the traffic signals of ICD-10. They tell coders exactly when to stop, when to yield, and when to add more info. Let's slow down for a second, because this trips people up all the time. There are two different types of excludes notes. Excludes 1 is a hard red light. It means not coded here. Two conditions simply cannot occur together, like having a congenital, meaning from birth, and an acquired form of the exact same condition. You must stop. No way can you use those codes together. Excludes 2, however, is more of a yellow light. It means not included here. The condition isn't part of the code you're looking at, but a patient absolutely can have both conditions at the exact same time. If it makes sense, you can go ahead and use both codes.
Moving on, you'll also frequently see instructions to code first or use additional code. This enforces a very strict sequencing rule. Step 1, you must always sequence the underlying etiology, or the cause, first. Step 2, the manifestation, or symptom, has to go second. In fact, if a code title literally says "in diseases classified elsewhere," that means it's a manifestation code, and the rules say it can never ever be listed first on a medical record.
And if you ever find yourself getting confused, the official guidelines provide a crystal clear hierarchy. To quote the text directly, the conventions of the classification take precedence over guidelines. This basically cements the absolute, unquestionable authority of the structural conventions we just talked about, like those excludes notes and sequencing rules. The conventions always win out.
Section 6. Why this precision matters. The real-world impact.
So, why go through all this trouble? Why have such an obsessive level of detail and strict grammar? Well, it's necessary for a few massive reasons. It ensures total data integrity, meaning your medical history is accurate no matter which doctor you see. It guarantees proper tracking of patient care and prevents really dangerous medical coding errors that could literally alter a treatment plan. Plus, on a macro level, it facilitates perfectly accurate statistical records for public health. This is what allows organizations like the CDC and the WHO to track diseases across the entire globe with complete precision. The ICD-10 really is a vast, invisible language humming behind the scenes of global healthcare. Next time you visit a doctor, consider the immense machinery at work. How will your completely unique, complex human experience be seamlessly, perfectly translated into this strict alphanumeric matrix? It's definitely something to think about. Thanks for joining me for this explainer, and keep questioning how the world around us is put together.